Influenza is a very common illness in children. It is caused by subtypes of virus A, B, C, and D. Of these, two subtypes A and B are known to cause seasonal flu in children. Along with being very common, it can also be potentially fatal. Like a recent meta-analysis from India reported that there were 27,825 deaths in 1 year in India. So recently, the American Academy of Pediatrics has come up with the recommendations for prevention and control of influenza in children applicable for the year 23-24, and I decided to make a video on the same. But before that, I would like to take a moment to thank everyone for participating and being a part of my endeavor for child health. Of course, this channel aims at clearing your concepts and keeping you updated. I am overwhelmed with so much of love, appreciation, and respect, and this is what keeps me going despite sometimes being so very busy on the chair I'm currently at. Thank you for all the motivation. So the key updates for the year 23-24 influenza season include: the composition of the vaccine has been updated, recommendations for immunocompromised hosts have been clarified, improving access to influenza vaccine has been emphasized, and indications for influenza testing have been highlighted. So when we come on to the components of the influenza vaccine, they are basically the two major viruses, influenza A and B, are included. In influenza A, two strains H1N1A and H3N2A strains have been included, and in influenza B, Victoria B and Yamagata B strains have been included. Of these four strains, in the current season, H3N2A, Victoria B and Yamagata B, these strains remain unchanged. But influenza A H1N1 PDM09 component has been added in this season to the vaccine. Besides this, the trivalent vaccines, it is important to remember that the trivalent vaccines do not include the Yamagata B component of influenza B virus, as we'll see further. There are certain high risk groups which have been defined by American Academy of Pediatrics for which are prone to develop influenza related complications. These are defined by demographic factors like children less than 5 years, especially less than 2 years, children born preterm or near term, residents of a chronic care facility or nursing home, then underlying conditions like chronic pulmonary disease, asthma, cystic fibrosis and bronchopulmonary dysplasia, cardiovascular disease which includes hemodynamically significant conditions, kidney disease like CKD and patients on dialysis, hepatic disease like chronic liver disease and cirrhosis, hematological disease like sickle cell disease and other hemoglobinopathies, metabolic disorders like diabetes mellitus, neurologic and neurodevelopmental conditions like cerebral palsy, epilepsy, stroke, intellectual developmental disorder, moderate to severe developmental delay, muscular dystrophy, spinal cord injury, and immunocompromised states like receipt of immunocompromising medications, receipt of bone marrow hematopoietic stem cell transplant or solid organ transplant, congenital or acquired immunodeficiency including HIV, asplenia, and those receiving treatment with aspirin or salicylate containing therapies. So coming on to the type of influenza vaccines, just a word about them. Basically, there are three types of vaccines available in the market. First is the inactivated influenza virus vaccines, which can be administered to babies who are more than equal to 6 months of age. Then the live attenuated influenza virus vaccine, which can be administered to children more than equal to 2 years of age. And the last is the latest edition, the recombinant influenza vaccines, which are administered in the age group more than equal to 18 years. What is important here to remember is that the inactivated influenza virus vaccines are again of two types, trivalent and quadrivalent. Trivalent, as I had discussed earlier itself, does not have the Yamagata B component. The live attenuated influenza vaccine cannot be given to patients who have experienced severe allergic reactions to the same in past, who have received aspirin or aspirin containing products, who have immunodeficiency with chronic medical conditions as discussed earlier, and who have taken influenza antiviral medications in the previous 48 hours. So coming on to the actual AAP recommendations for this season, The first is that everyone 6 months or older needs to be vaccinated this year. Any licensed vaccine product can be used, and there is no preference of one product over another, including inactivated and live attenuated. Live attenuated should not be used for immunocompromised persons. The number of vaccine doses for children remains unchanged. That we'll discuss later. And the AAP supports mandatory influenza vaccination of healthcare personnel also as a critical and crucial strategy for reducing the healthcare associated influenza virus infections. Besides this, children 6 months to 8 years of age should receive 2 doses of influenza vaccine at least 4 weeks apart if they are receiving it for the first time, or they have taken only one dose before the 1st of July 2023, or in case their vaccination status is unknown. So it is absolutely safe for them. All the other children who do not belong to the above 3 criteria should receive one dose this season. Doses given up to 4 days before the minimum suggested interval should be regarded as acceptable, and if a child is inadvertently vaccinated with an adult formulation like RIV or LAIV to less than 2 years of age, the dose should be counted as valid. And if a lower dose is inadvertently administered, then a repeat dose should be given as soon as possible to make it 0.5 ml to offer complete protection. Also, if 2 doses need to be given in a season, the doses need not be of the same brand. As I had already stressed earlier, a child may receive a combination of inactivated and live attenuated also, if it is appropriate for age and health status, that is a child more than 2 years of age and not suffering from any of the contraindications for live attenuated vaccine. Then vaccine should be offered as soon as it becomes available. The recommended dose should be received by the end of October this month for optimal protection. Inactivated influenza virus vaccine or recombinant vaccine, if appropriate, may be administered simultaneously with or at any time before or after other inactivated or live vaccines, and live vaccines may be administered simultaneously with other live or inactivated vaccines, including COVID-19 vaccine. But if it has not been administered simultaneously, then a gap of at least more than equal to 4 weeks should pass between the administration of LAIV and other non-oral live vaccines. Now coming on to certain contraindications and precautions. There are certain product-specific contraindications which you must see in the product insert of the vaccine. Then severe allergic reactions to previous influenza vaccine administration is a contraindication for administering the vaccine. Just in case this happens, an allergist should evaluate as to which component of the vaccine was responsible for this reaction and to determine whether future vaccine receipt is appropriate or not, and then the decision should be made ultimately. However, if children have egg allergy, they can receive any influenza vaccine without additional precautions. One must remember that mild illness, including a low-grade fever, children can still be vaccinated. Influenza testing is recommended in presence of signs and symptoms of influenza when test results are anticipated to impact the clinical management. For example, to inform the decision to initiate antiviral therapy to the parents, pursue other diagnostic testings, initiate infection prevention and control measures locally or otherwise, and distinguish from other respiratory viruses with similar symptoms like SARS coronavirus 2. When influenza is circulating in the community, for example, hospitalized patients with symptoms should be tested with a molecular assay like RT-PCR, and at-home tests, for example, when are available for children as young as 2 years of age, but data on the use of these tests is still limited in the pediatric population. Coming on to the treatment, especially inpatient ward, oseltamivir is the preferred antiviral medication. Why am I saying this? Because other antiviral medications like zanamivir are also there in the market. Best results are observed when the drug has been administered within 48 hours of onset of symptoms. But in case this has not been possible, then even after 48 hours, one must not withhold administering the drug. Antiviral treatment should be offered as early as possible, regardless of the influenza vaccination status. In any child hospitalized with suspected or confirmed influenza disease, any child with severe disease, even on an outpatient basis, and any child at high risk for developing influenza related complications, as we had discussed earlier, regardless of the healthcare setting. Also, starting antiviral therapy does not require a positive test per se. So even on clinical suspicion, if the person has risk factors, is hospitalized or has severe symptoms, then you can start oseltamivir. Treatment may be considered in any child with suspected or confirmed influenza disease in OPD basis if the person is not at high risk for developing influenza complications, and the treatment can be initiated within 48 hours of symptom onset, or in patients whose siblings or household contacts are either young than 6 months or are at high risk for developing influenza complications. As I have told you in previous scene, there are basically two drugs. Oseltamivir is used for chemoprophylaxis and for use as treatment in children more than 3 months of age. Zanamivir is, on the other hand, approved for children more than 7 years of age only. So these are the recommended treatment doses and durations. Like in less than 3 months of age, prophylaxis is not applicable. In 3 to 11 months of age, the prophylactic dose of oseltamivir is 3 mg per kg per day OD for 7 days. The treatment dose is 12 mg BD for 5 days in less than 3 months of age, 20 mg BD for 5 days in 3 to 5 months of age, and 25 mg BD for 5 days in 6 to 11 months of age. Now, more than equal to 12 months of age, the criteria is according to the weight. If the weight is less than 5 years, the prophylaxis dose is 30 mg OD for 7 days, and in treatment you give the same BD for 5 days. In the weight band 15 to 23 kgs, you give prophylaxis with 45 mg oseltamivir 24 hourly for 7 days and 45 mg 12 hourly for 5 days. In the weight band 24 to 40 kgs, you give 60 mg OD for 7 days and 60 mg BD for 5 days. And in the weight band more than 40 kg, you give 75 mg 24 hourly for 7 days and 75 mg 12 hourly for 5 days. As regards chemoprophylaxis, any child who is at high risk for developing influenza complications and for whom the influenza vaccine is contraindicated, or who has received influenza vaccine in the past 2 weeks but optimal immunity might not have yet been achieved, or may not have mounted a sufficient immune response because of immunosuppressive state, or when the influenza virus strains circulating in the community do not match with those of the seasonal influenza vaccine, these patients need to be given chemoprophylaxis. Also, other categories who need chemoprophylaxis are family members and close contacts of children at high risk for influenza complications and those likely to have ongoing close exposure to influenza. Similar is the category of unvaccinated staff and children living in a closed institutional setting with other children who are at high risk for developing influenza. So these are the indications for chemoprophylaxis. Oseltamivir, as discussed earlier, is the drug of choice for chemoprophylaxis, except for in the age group less than 3 months when chemoprophylaxis is not recommended. And optimally, the post-exposure chemoprophylaxis should only be used when antiviral agents can be initiated within 48 hours of exposure. So I guess this video proves helpful to you both for in your OPD consultation practices and for the postgraduates for writing the examinations. Thank you so very much for a patient listening and watching, and please do share the knowledge, and I shall be glad if you have any questions and you put up in the comment box below. Thank you.